Okay, well, good morning, everybody. This is Tony Frazee. I'm the benefits specialist over here with Art Jetter. I've got 11 o'clock, so we're going to go ahead and get started here today. Basically, today we are pleased to welcome here Jamie Sarner, the National Sales Director for Aetna. Going to be going over Aetna Recovery Care with us today. Expecting this to be a really great session. Pretty hefty turnout here, so I'm definitely happy to see that. Before I turn this over to Jamie here, just a quick reminder, we're going to make sure and be answering everybody's questions as we go, so if you want to feel free to type those in the question or chat box, we'll get those answered for you at the end of the session here today. Other than that, Jamie, I'm going to turn this thing over to you, sir.
Tony, thank you. Tony just told me how many people we have on here, and that is awesome. So I'm excited to get started. So with me and Aetna, I am a national sales director, but I'm also an agent. So I'm going to talk to you guys today about how to place this, what the plans consist of, because we're going to go over two plans, Recovery Care and Home Care Plus. They're two great plans that you can use anytime that you're finding someone that's in need of nursing facility care, assisted living, home health care. And want to make sure that you see these couple of slides here from Art Jetter and Company, making sure you know everything that's going on. And at the end, we're going to throw up some Q&A. So like I said, great to be here. And first of all, currently, Medicare has 61 million beneficiaries. That is a lot of individuals on the system that the government's paying for. I can't stress enough, how important this number is, because when you turn 65, Medicare doesn't get to pick and choose who they want. They get everyone. If they're in the middle of chemotherapy, if they have epilepsy, they have any type of health issue, Medicare is going to inherit that. And that's not something that Medicare can control. It is definitely a deficit for them. That's about 18% of the US population, and that's going to keep growing. It's going to keep growing so much that enrollment is expected to rise to 79 million in just 8 more years. So that's also a devastating number for Medicare. And I point that out because you're going to see lots and lots of changes, no matter if it's Medicare Supplement, Medicare Advantage, the way hospitals pay, nursing homes pay, home health care pays, anything that has to pay for the older generation is going to go through a lot of growing pains. And the government is one of those. So I want to make sure you're aware of that. And if you can point out to a client or a to-be client that you're trying to get on the insurance, it's important to know what's going on in the background. And for those of you that have heard me speak before, I talk a lot about Medicare and where Medicare's going, because I think that is the pathway to the sale. And for instance, Medicare is trying to save money desperately. And one of the ways that they figured out how to do this is if they construct these penalties, and hospital penalties in particular. So what they're doing now is this. Medicare has figured out through the years that Part A, hospitalization, costs them the most amount of money. It's actually not Part B. It is the hospital, the room, the private room, the skilled nursing care, the home health care, and the hospice care. These things cost millions and millions of dollars every year. So when Medicare looks at what's costing us the most money, number one is hospital readmissions. Believe it or not, 1 out of 5 people that enter a hospital that are on Medicare end up coming back within 30 days of being discharged. And Medicare does not like this. They say that the hospital should have done a better job and they wouldn't be coming back into the hospital for a second trip. And remember this, Medicare pays day one in the hospital, after the Part A deductible, but they're still paying day 1 through day 60. So if a patient has to come back into the hospital within 30 days of being discharged, they're paying all over again. They do not like it. So what they've done, they've said, hey, we're going to start penalizing hospitals if they readmit too many of these patients. And here's what it looks like, just a glimpse.
Patients are being readmitted to hospitals. Officials say it's costing you billions of dollars a year. Now, several Indiana hospitals are looking at fines because of it. 66 Indiana hospitals will be docked $12 million total next year. That's in Medicare payments. Federal officials say too many patients came back for care within a month of being discharged. Only 17 hospitals in the state will not be penalized. Officials say readmissions are often unnecessary. They say it's usually because of treatment that should have been prescribed during the first visit.
All right, you heard that. Treatment that should have been prescribed during the first visit. So Medicare blames the hospitals for them having to return. So here's what it looks like. They can fine a hospital up to a 3% penalty. So what's that mean? What's the 3%? That is all of the Medicare reimbursement money that the hospital receives from Medicare. All of it. That's everything. That's not just for the one patient. That's all of the money that flows through the hospital can be penalized up to 3%. And if you look, this has actually been going on since 2015, and it will continue. They're saving millions and millions of dollars a year.
Hey,
So,
Jamie.
Yes.
I'm getting a question. I don't think any slides are advancing. I got people there sending messages over, so nobody's seeing any slides advancing. We're still showing on the Aetna Recovery Care Home intro screen is all we're getting. So I just want to make sure you're aware of that.
Well, I apologize, everyone. Let's see what's going on here. I know you can probably see that, even though, let's see, and we can play around with this a little bit. Tony, can you see that screen that shows
the
hospital penalties?
Yep, I'm seeing that screen.
Okay, what we're going to do, everyone, we're going to just my slides aren't going to move, but that's okay. It's more important that you see them. So what I was showing earlier is Part A, hospital rooms, skilled care, home health care, hospice care, and the penalties that go along with those. So it looks like this. Up to 3% of the penalties, hospital Medicare reimbursement. It's been going on since 2015. And you can see there's the hospitals on the left. And I just chose a couple of the, I wanted you to be able to see that it's all over the place. 0.10, 0.25, there's a 3%, a 2.21. And it really just depends on how many patients are going home from the hospital and then returning within 30 days. So this is real money to a hospital. And it's hard for them to figure out, okay, how do we fix this? They do follow-up phone calls, making sure that people got their, patients got their prescription drug, their new prescription drug order filled from the pharmacy, making sure they're drinking plenty of fluid so they don't get dehydrated, because that's a big reason why they have to come back, but they're still getting readmissions coming back into the hospital. More penalties and more savings. So the next one to come along is the big business of Medicare audits. And these audits all started because Medicare said, you know what? We need to make sure that hospitals are not admitting patients just willy-nilly. They come in the emergency room and they're just saying, you know what, let's put them in as inpatient, because that Medicare is going to pay us, the hospital, the most amount of money possible. So CMS started the 2 midnight rule. The 2 midnight rule states that inpatient admission and payment are appropriate when the treating physician expects the patient to require a stay that crosses 2 midnights and admits the patient based on that expectation. So what do those words mean? When an individual comes into the hospital, it is typically through the ER. The doctor on call has to make the decision, does this patient need to be in our hospital for at least 2 midnights? And if they do, I have to show, the doctor has to show documentation that here's the reason why they need to spend the night in the hospital for 2 midnights. If they do admit the patient without them needing to stay 2 midnights, that's when the penalty is going to come in. And how are they going to do that? I'm going to show you. Medicare recovery audit contractors. These are third parties hired by Medicare to determine the legitimacy of each patient's hospital admission. So they get to come in to the hospital. They will look at all of the medical records for each Medicare patient, and they're going to determine if the hospital did the right thing. Did they follow the 2 midnight rule? If a hospital makes the wrong decision and admits a patient to inpatient status, the auditors can determine that the hospital stay is invalid. If the admission's invalid, the hospital will lose all of its Medicare reimbursement for that hospital stay. So this isn't the 3% of all the Medicare money coming in. This is 100% of that patient's stay. So basically this, they make the wrong decision, Medicare is going to take away 100% of the one patient's reimbursement money. The hospital cannot in turn charge the patient. So the hospital would basically have to eat those costs because they did the wrong thing. And the amazing thing is this, the auditors, the way that they're paid, they receive compensation from Medicare for each of the invalid hospital stays they find during the audit. So what they say now is that Medicare is backed up more than a year because these auditors are sending anything and everything they can. If it's close to the hospital making the wrong decision, they send it because maybe it'll favor to the auditor's way and they're going to get that compensation. So hospitals are at this point where they're like, okay, what in the world do we do? We're losing a lot of money by doing this. And you all know the answer to this. I preach it all the time. I have for years. But the best way for hospitals to avoid these penalties, it is observation status. You all are very, you know observation status. You're very familiar with it. And it's important to know why it's on the rise. It's on the rise because hospitals are using it to avoid these penalties. And the reason being, you know, an outpatient observation stay is less expensive for Medicare than an inpatient stay. They're getting basically the same care. It's just Medicare treats it different and pays the hospital a lower wage for that. So what's that mean? Hospital observation status is a designation used by hospitals to bill Medicare. People who receive care in hospitals, even overnight and for several days, may learn they have not actually been admitted as inpatients. Instead, the hospitals classified them as observation status, which is an outpatient category. So everything's going to flow through Part B, medical, B as in boy, and it's not going to go through the Part A. So it is just billed totally different. So observation status is one of the biggest threats facing seniors. And this is the reason. For those of you that haven't seen this video, and if you have seen it, I want you to see it again because we're going to talk about it, but watch this.
Good. 79-year-old MJ Bricu is doing therapy after a bad spill in September. She spent 3 days in a hospital. She got the same care as an inpatient, but she wasn't classified as one. Instead, her chart said she was only under observation.
I mean, it's illogical. I had a broken leg. It just didn't make sense at all. What were they going to observe?
And here's what she didn't understand at first. That label, under observation, technically made her an outpatient. And that means Medicare won't pay for her rehabilitation in a nursing facility, which costs $28,000.
The whole thing is so outrageous and it's not right.
It's a huge problem. There are over 1 million, almost 2 million people every year who are stuck in this observation status, Alice in Wonderland.
To the patient, to our viewers, frankly, it seems like the hospital shares at least part of the blame for this.
Sure, they're in the hospital. They're going to think all of this is a hospital decision. Much of this is out of our hands.
Rich Umdenstock, who represents most of the hospitals in this country, says they're being squeezed by Medicare. Inpatients cost more, so Medicare aggressively audits the classifications given to patients.
If you make the wrong decision, if you admit a patient to inpatient status, and then they determine after the fact, sometimes years later, with additional information the physician didn't have, they will take that payment back. Unfortunately, the patient does get in the middle of this.
We wanted to talk to Medicare, but they denied our request for an interview, citing pending litigation on this very issue. The hospital that treated Mary Jane wouldn't talk to us either, but gave us a statement saying it is obligated to follow Medicare rules when assigning patients to their appropriate level of care. MJ finds the whole thing unfair. She and her husband, who's had Parkinson's for 20 years, just moved in with their son in Dallas to save money.
I've worked my whole life, and I'm just appalled.
Now any money they can save will go to her rehab.
So $28,000 for just a broken leg. And I want to make sure that everyone understands she was only in there 20 days. So how can 20 days in a nursing facility cost $28,000? It is amazing. When you have insurance, they will take a different rate. When you have no insurance paying whatsoever, because Medicare said they're not paying for that, she was not considered 3 days in a hospital prior as an inpatient, they can charge whatever they like. So this video has been around for years, but I don't want you to think this isn't happening. This is happening all the time. When it first started, you had every news organization on this, and you can actually get, you can Google hospital observation stays, and you will see tens of thousands of articles on this. I scour all the time, and I do have other videos. This one shows the direct impact on someone on a fixed income spending $28,000. So how do you fix this? Why did it happen? I will show you. You know, most of us on this call know that Medicare CMS has a 3-day prior hospitalization before a skilled nursing facility admission is payable. Medicare beneficiaries meet the 3-day rule by staying 3 consecutive days in one or more hospitals as an inpatient. Hospitals count the admission day, but not the discharge day. Time spent in the ER or in outpatient observation prior to admission does not count towards the 3-day rule. So there you go. They have it even in the definition now about observation stays. So even though she spent 3 nights in there, she was in the hospital bed, had the hospital gown, the bracelet, the whole thing, she was not considered an inpatient. Therefore, she's not going to get her 20 days paid of skilled nursing. And this is a huge, huge problem for the traditional Medicare people out there that have, like I said, traditional Medicare and a Medicare supplement, because if Medicare does not approve and pay the first 20 days of skilled care, their Medicare supplement will not and cannot pay day 21 through 100. So they basically have no coverage. And for those of you that have clients out there that have a long-term care plan, about 93% of long-term care plans have an elimination period of 90 to 100 days. And I get that. You know, if Medicare and a Medicare supplement's going to pay it, what's the big deal? Give an elimination period of 90 to 100 days. Most long-term care, you can't get anything lower than that. But these people are vulnerable now because of observation stays. There's a lot of money at risk because there's no insurance the first 100 days. Medicare Advantage folks out there, it's still very important to make sure they have something to fill the gaps. But I will say this, Medicare Advantage does not follow this rule of a 3-day prior hospital stay. They actually do not require that you stay in 1, 2, 3 days. There is no rule on that. It doesn't matter if you're inpatient or patient. Typically, a Medicare Advantage plan is going to pay the first 20 days. Where the issue comes in for those individuals is day 21 and up, because there's a large out-of-pocket amount, daily amount. So it's important for them too, but just remember this. The traditional Medicare folks out there have a huge problem. So I want you to see this. There are many, many lawsuits that went on after individuals went into the hospital, went into skilled care, ended up paying all of this money out. So instead of changing the rule, the 3-day rule, they said, well, we'll just make sure people understand the rule. And what they developed was this: hospitals must give notice of observation status within the first 24 hours of confinement. So if they're in the hospital, they've been put in observation status and they don't know it, the hospital must approach them within the first 24 hours. And this form over here to the left, all treatment under observation falls under Part B of Medicare, which does not pay for the patient's rehabilitation in the skilled nursing facility. The patient will have to sign the Medicare observation notice acknowledging their own financial responsibility for any and all costs not covered by Medicare. So it's a big deal. And here's what it looks like. This is a more close-up view. So it will say Medicare outpatient observation notice. You're a hospital outpatient receiving observation services. You are not an inpatient because observation services affect coverage and payment of your care after you leave the hospital. Then they're going to have them sign it, date it, and timestamp it. So here's the story on that. They will read this to them, they'll let them read it, they'll sign it, and that way they've been served. They know now that they're on the hook if they go into a skilled nursing facility. Although you and I both know people don't understand what they're reading here. And if they do understand it and they say, you know what, I don't feel comfortable signing that, I'm not going to sign it. The procedure in the hospital is this: the social worker, the hospital employee that is trying to get this document signed will go and get another hospital employee. So there'll be 2 of them that enter the room, and basically this, they will ask them to sign the paper again. If they refuse it, they will read it to them, and then they witness to each other that it was explained to them, but they refuse to sign. So either way, they're going to get, the hospital's going to get the disclaimer of saying, hey, they already knew that it wasn't going to be paid before they left the building. So when you see things like this, this is just one of millions. There's over 2 million a year that go into observation. Now, a certain percentage of those are going to go into skilled care. Some of those are going to go home. But this is a real issue for them. So what I want to show you is this. 2022, also for 2023, the new books just came out. I'm sure you're all aware of that. Every senior has one of these books in their home. They typically come out every September. So 2023 is out, and guess what? On page 28, the same as it was last year, you can show all of your prospective clients this page, and you let them know, hey, Mrs. Jones, Medicare, you know, these books are thick, a lot of information in there, but I can show you exactly what you're supposed to do and what you're not supposed to do. They're telling you here that you have an issue. If you're under observation more than 24 hours, you must get a Medicare outpatient observation notice. That is that form I showed you previously. Medicare only covers these services after a 3-day minimum medically necessary inpatient hospital stay. So they're going to see it in their own book. I urge you to use that book, whether you're talking to them over a Zoom meeting or just over the telephone or in person. Have them go get their book with their name on it. It really is impactful to them. They understand it. They know that it's nothing you brought into the home and you're showing them, and they might be skeptical about it. This is a real document that they'll understand. So, in saying all of that, Aetna's new look for recovery care is this. This is the brochure. They just put this on the portal this week, even though we changed the benefits around a little bit. So why the new look? Is this a brand new policy hitting the market? It's not a brand new policy. It's just a brand new refreshed look. So what they do is this. Whenever a big carrier files a new product in a state, what they will do, they will bracket those. So they'll start it off at $10 a day, and maybe they go up to $400 a day for a nursing home benefit or assisted living benefit. But they may not release the full 400. They say, you know what, we're only going to release 300 of that. But we filed it for 4. If we ever need to increase it, we can. And you can do that without refiling the product. So that's exactly what Aetna did. They had filed this up to $400 a day, and I'll show you on the next couple of screens here. But this is what the new brochure looks like. And again, it has a lot of good stats on there. The old stat is still a great one today, that at least 70% of people age 65 will need long-term care services and support at some point. So when you really think about that, 7 out of 10 people are going to need some type of care at some point. And that could be a month, a week of care, all the way up to 20 years of care. It's just, you don't know how long your type of care is going to be or what it's going to be. So also another couple of stats, every 65 seconds, someone's diagnosed with dementia or Alzheimer's disease. Lots of good stats here. Lots of good numbers to show the average cost of a private room at a skilled nursing facility is nearly $112,000 a year and projected to be about $141,000 by 2030. So trying to give as much information in a brochure as they can. And I'm a big believer in the brochure. I know when I leave a home, I'm an old face-to-face agent. And even if you're not a face-to-face agent, if you're out there, you're always going to mail the brochure. And this is what they have, right? Because they can't feel or touch the insurance. This is really the only thing they have until they get their policy. So I think it's important to make sure that it's user-friendly, agent-friendly, consumer-friendly, and it doesn't make you lose a sale. It just helps fortify the sale. And I also want you to see this. This page we got so much good praise on about more to consider. This shows exactly what does Medicare pay in a nursing facility. Well, they'll pay for 20 days after a 3-day hospital stay, but they won't pay for intermediate or custodial care. What do they pay for an assisted living facility? Medicare pays nothing for an assisted living facility. What's Medicare pay for home care? Medicare pays for eligible home care services like intermittent skilled nursing with doctor's orders. It does not pay for 24-hour-a-day care. So this kind of gives you the talking points of letting people know Medicare is going to be there, but it's very limited. When you think about going into a nursing facility, you don't want any restrictions. You don't want them to think that 100% of everything's covered, 100% of hospitalization, or 100% of home health care is covered, because it's not. And this will help you explain that. Now, this next slide is going to be very busy because this was supposed to open one at a time, so forgive me. A lot going on here. So the new brochure. Aetna went from $300 a day to $400 a day. So what that means is this: nursing facility, any nursing facility, does not have to be approved by Medicare. as you know, a lot of the nicer nursing facilities, nursing homes are not approved by Medicare. You can go, your clients can go to any nursing facility they like, in any state they like. Also, any assisted living facility that Medicare doesn't pay. And at $400 a day, you're looking at a grand total, if they take out a 360-day plan, $144,000 worth of benefit. So look at the top half of this, since it's pretty busy here. You can use that benefit twice in a lifetime. So if you choose a 360-day plan, you can use 360 times 2, 720 days of care over the lifetime of the plan. Now, there's also a waiting period. You can choose a waiting period of 0, 20, or 100 days. And I will urge you, always pick a 0 waiting period or a 0 elimination period. It's okay if you're duplicating those 20 days of Medicare, because Medicare may or may not pay it. Even on a Medicare Advantage plan, you can duplicate the first 20 days, because remember this is a true indemnity product. It's going to pay no matter who else is paying the bill. If the bill's paid in full, it does not matter. Aetna will still pay what they're supposed to. If it's day one, they will pay day one, and they will pay it directly to the insured. So that's important to remember. So a 0 waiting period is always best, and you can choose the benefit period. A 90-day plan is still a fantastic plan. 180-day plan, 270, or 360. It's 5 days short of a year, because if it were 365 days, then it would be considered a long-term care plan. And we don't want that. And the main reasons are this. With this not being a long-term care product, it doesn't have rate increases the way long-term care does. It doesn't have the high initial premium as long-term care does. It also doesn't have the underwriting hurdles that long-term care does. You will find that this plan has less underwriting questions than Aetna's Medicare supplement. You will find that Aetna Continental Life has had short-term care since 1996, and they've never had a rate action. These premiums are stable and secure. Can they have a rate increase? Yes. Have they ever? No. And these plans are doing great. Actuarially, they are perfect. So you don't have to worry about that anytime soon. And there is a hospital benefit included with this, with the base plan. There is a $10 minimum that's added to each of these products. But if you choose to give them a daily hospital benefit, you can. You can go up to $400 per day. So what is the only option on this plan is going to be the home health care rider, which, think of it as 2 plans in one, because the home health care side of this is totally different benefit. You can have 360 days of nursing home or assisted living above, and you can choose a 52-week additional for home health care. And it's a weekly benefit, not a daily. So you can go up to $1,200 per week, and you can choose 13, 26, or 52 weeks. So think about that. That's 2 years uninterrupted coverage. If someone, for instance, said, okay, I want to keep my mother at home as long as I can. So I'll try to keep her here for a year. If it's not working out or she's not getting better, we can transfer her over to an assisted living or a nursing facility the very next day, and you can. So if you look at the total on home health care of $62,400, add that to the above, you've got $206,000 worth of benefit. That you potentially could use twice in a lifetime, because you can use the home care rider twice also. So that is a lot of coverage for not a lot of premium. So I urge you to look at those. And when you see the total brochure, and you can order that right now, you will also see this. It says, did you know nursing facility care can include, and it's giving them a peek of what this plan can pay for. 24-hour care, cardiac care, stroke, rehab, doesn't matter what the condition is, they can have the care they need in a nursing facility. If it's an assisted living facility, these beautiful assisted living facilities that look like 5-star hotels where they have daily meals, they monitor medication, 24-hour care, recreational activities. People would much rather go to an assisted living than a nursing home, and it's great that they know they have the option with this plan. Home care, they will see that it's not limited to just rehabilitation therapy, physical therapy. It also can take care of the custodial needs such as housekeeping chores, laundry, cooking meals, shopping for groceries, bathing, shopping, therapy, anything they need, it will be there for them. And we also have down here more about the plan, because these are questions a lot of agents ask because their clients are asking, who gets paid the benefit? As I said earlier, benefits are paid directly to the insured unless they want them to be paid to the nursing facility or the home health care agency. Are benefits taxable? The answer is no. These benefits that come into the insured are theirs to spend any way they like. It does not matter. They're not restricted. Pays in addition to any other insurance. Again, I said that earlier. Does not matter if they have other insurance that pays it. This plan's going to pay the full amount. And I didn't say this, but let's say that they go to a nursing facility that's only $250 a day. The plan is still going to pay $400 a day. And guaranteed renewable for life, that's always good to know. As long as the premiums are paid on time, they can never be dropped. And as I said before, since 1996, people have had these plans pay without ever having a rate increase. So that's huge when you're talking about seniors. And I say this all the time to them, Mrs. Jones, you're on a fixed income. You should have an insurance that's not going to keep going up on you year after year after year. And the track record is this. So any of you that, and most of you that know long-term care, I'm sure you're familiar with Genworth Cost of Care. I love their website. It's an amazing website because you can sit there and figure out exactly what the cost is in a particular state, in a particular city. And I love that it's very interactive. I can sit there with a client, a Zoom meeting or in person, and really get them to understand what the cost is and what they're up against. So here's what's going to be coming. This isn't in there today because I just got it approved, but you're going to have this. This is going to be a separate sheet, and there'll be more to it than this. But it's going to say more to consider, and it's going to say what is your healthcare cost instead of what's your cost of care. But it's going to look very similar to this. And if you go to the Genworth Cost of Care site, you can fill this out with your client. And this is just an example of how much it costs, $268 a day, what it is monthly, what it is annually. You know, I can say it, and you can see it. When your client can see it and they see how much this really is costing if they unfortunately have to use it, this will help you very much, I feel, because it's something you can use or you don't have to use it. This will eventually be in the kit, and like I said, if you think it's a valuable piece to you, please use it. If you don't, you can just tuck it to the side. So add any recovery care to any underwritten Medicare supplement with no additional underwriting. So what that means is this. It should say any Aetna Medicare supplement. Anytime you're bringing up an Aetna Medicare supplement, as I said before, that underwriting has more questions than the recovery care does. So there is no additional underwriting. You can add even a 90-day plan. And just to give you an example, a 90-day plan for a 65-year-old person, first aid coverage for nursing home and assisted living. I'm not adding home care to this, but if it's a plan that pays $3,000 a month for 90 days, it's about $16 a month in premium. Very inexpensive. So I'm giving you the least amount you can offer someone. Before I walk out of someone's home with no sale, I'm definitely going to offer up a 90-day plan at the base and help them. And in helping them, that could grow into something else. They may call you back a year later and say, hey, I want to upgrade that. Here is what the Recovery Care National footprint looks like. And at Aetna, they are working very hard to get into the states that you don't see that aren't green yet. So as we speak, they are wheeling and dealing with certain states to see what it would take to get a product in there. And a lot of times, certain states will say, you know what, we want you to strip down this and not add that and not have this. If the product isn't worthwhile, Aetna's not going to launch it there. So that could be a reason, but I want you to know there's an all-out effort to get into these states that we're not in, especially Florida. So just to give you that idea. Now, I want you to see this, and we're at the end of this right now. When your applicant doesn't qualify for recovery care, what I want you to do is to drop back to this. I want you to go to Home Care Plus. This is a separate plan than recovery care. A lot of you on the call know this plan. Just like the recovery care plan, there is no height and weight chart. All of Aetna's plans have a quick view underwriting drug list because they do not want you to submit an application and maybe they're taking a drug that wouldn't be covered or wouldn't allow them to have the coverage. We don't want you to submit an application and have it decline. That's the last thing Aetna wants. They want you to know when you're talking to that applicant if they're going to be able to get the plan or not. So that's why there's a quick drug viewing drug list, and it's very easy and simple. There is no underwriting phone interview like long-term care. Aetna does not even order medical records. They're not required. So they're not going to go off that at all. No hospital stay required. That's why it's great for observation stays, and renewal premiums, as I said, do not increase. Don't forget, Aetna has the e-app with the personal security question. You can ask something as simple as, Mrs. Jones, what's your mother's maiden name? You can type it in and it will sign everything for the applicant. Banking information, HIPAA information, everything is signed and finished. Nothing has to bounce back to your applicant. It's a done deal. And underwriting, once it's submitted, takes about 5 minutes. It's all done automated. So what they're going to do in the background, and this goes for the recovery care also, as it does the Home Care Plus, they're going to pull in the background when it's submitted with the e-app an RX check. So it's going to see everything that your applicant's taking as far as medication goes. And as long as everything was answered no on the application, and there's nothing on the declinable drug list, it's going to be issued right then and there. But my whole point in showing you the Home Care Plus is this: if your applicant gets rejected on recovery care, you want to fall back to this plan immediately. And here's the reason. All of these conditions are acceptable under Home Care Plus. These would be a decline on the recovery care. But Home Care Plus, they will do this. They will issue these conditions. And you see Alzheimer's, dementia, Parkinson's, oxygen use. And I know you probably go, how in the world can Aetna pay for home care when they have these issues? Here's what's different from the recovery care. On recovery care, you can have any type of home health care that you need. Doesn't matter, medical, non-medical. On the Home Care Plus, it's only going to pay for medically necessary home health care, meaning it has to be a visit, 3 1-hour visits a week for at least 1 hour on separate days. And here's what's going to happen. It has to be a physical therapy, speech therapy, respiratory therapy. It could be wound care, intravenous drugs. It's not going to take care of the day-to-day care of an Alzheimer's patient under Home Care Plus. Now, recovery care, home care will take care of an Alzheimer's patient, but you can't have Alzheimer's when you take out recovery care. So what I let all of my clients know is this: listen, this plan's not going to take care of the day-to-day care of your mother that has memory loss. But if your mother has a stroke, a heart attack, falls and breaks a bone, she needs physical, speech, occupational therapy, and she gets just 3 visits per week, she's going to get the full $1,200 a week. And she can use that money any way she likes. She can use it to pay for those 3 visits. She can also use it to pay for items that aren't covered under the policy, because that $1,200 is hers to spend as she wishes. If she wants to pay for additional care, she can use that money to do that. So you'll see here that the benefit looks a lot like recovery care, that it's a $1,200 per week, 13, 26, 39, 52 weeks. It also has a hospital indemnity up to $300. But the trigger for this plan is not like recovery care. It is not 2 ADLs or cognitive impairment. It's actually all the doctor needs to say is that they need medically necessary home care in the home. And that's going to suffice for getting the care and having it paid. So 2 totally different plans, even though they're very similar, 2 totally different underwriting ways of going at it here. So I would just want to make sure that you know, I know that we've jumped around here and I've kind of been all over the place with my slides being the way they are, but I appreciate you listening to this so far. And here is exactly the footprint. Texas does have Home Care Plus. And as I said, we're trying to get other states. And I'll let you know, South Dakota, I think, just got approved for this. Hasn't been launched yet, but it will be coming. And you may say, why South Dakota? Like I said, we're trying to get in all the other states. That's a state that we weren't previously in. And I'm glad to say we're going to be there. So, like I said, all of these different slides you've seen here, we've covered a lot. I always feel you need a reason. When you're selling a need to someone, I'm very big on selling need. I believe that people will pay whatever the premium is if they feel it's worthwhile and they see the need in it. So the need is great out there right now. It's going to continue to be great, because Medicare's not going to reverse the engines and say, okay, let's give a lot of money to nursing homes and start paying for everything out there. They're going to be taking away. It may look at times like, oh, look, there's extra benefits coming. Don't be fooled by that. There's going to be major changes in these next 8 years. That doesn't mean you have to wait 8 years. They're happening every day now. So I will always make sure, Aetna will always make sure, and I know Art Jetter and company, along with Tony, will always make sure you have everything that's up to date and what's happening out there in the news. So if we have time, I'd love to answer questions if you have any.
All right. Well, thank you, Jamie. I got to say, we do happen to have a few other questions here for you. First question I have comes from Sherry. Says, who do you have to hire? RN, LPN, CNA, family members, and/or friend? Question mark. I think you kind of touched on this a little bit, but the question is who do you have to hire? Either registered nurse, LPN, CNA, or family member or friend? Does the person I pay, that I pay for services rendered? Well, that's a different question entirely. We'll go with the first one there first with you there, Jamie.
Yeah, sure. Great question. So yeah, we get asked this a lot. So it's going to be this. Think of it this way. It always has to be someone that works for a home health care agency, because what they're doing is That's the trigger, right? In recovery care, if they can't perform 2 of the 6 ADLs or they're cognitively impaired, a home health care agency would be hired. It doesn't matter if it's medical or non-medical. It can be an RN, LPN, any of those things. It cannot be a family member or a neighbor. It would have to be some employee of a home health care agency. Now, I had this recently. I had a daughter that was helping her parents. She worked for a home health care agency, and the home health care agency actually sent her there. Guess what? That was paid. So again, doesn't pay a friend, relative directly. It always has to be home health care agency. Funnel that way.
All right, appreciate it. Then I guess kind of along the same lines, but I think again we probably might have already answered this question there. Does the person I pay for services rendered have to declare this as income, even a family member? I think we already established how that works there on that one there. Let's see now. One question I've got here. This is part of the scope of appointment? Question mark. Not sure.
Yes.
Yeah, I believe it is right. First, what they're trying to say.
Sorry, Tony. It is. It's under. It's kind of. I apologize. I didn't mean to talk over you. But yes, this is on the scope of appointment and is just under other products. It is. This is kind of the. You would check mark the same thing for like a hospital indemnity plan. This is a health product, and yes, covered under the scope.
Perfect. Let's see. And then is Texas the only state that offers Home Care Plus?
No. All of these in the green will offer Home Care Plus. Texas, I need to change my slide. I'm sure they have one now that shows it. But no, Texas was a late arrival to these before they finished or after they finished this slide. So everything you see on here that's the teal color and Texas have Home Care Plus.
Perfect. I got one of the questions here was, will these satisfy the LTC personal requirements to opt out of Washington Care's payroll tax?
Well, the plan's not available in Washington State, and no, it would not. So I will tell you, I truly believe, and I'm pushing, we are working very closely right now with NAIFA nationally, and we are trying to get the word out that this is a great alternative to what's spreading, because there's a lot more states that are going to be adopting the Washington guideline as far as long-term care goes. But I think this would be a better alternative. But no, you can't use it currently.
Perfect. All right. Thank you, Jamie. And then I know we have an inquiry to let us know if it's coming to Colorado anytime soon, as far as that goes. So let's see what else we got going on here. Looks like, is the recovery care available in Texas is the next question there, Jamie.
Recovery care is available in Texas and in Colorado. Just want to make sure that you know recovery care is in Colorado, just not the Home Care Plus. So you do have recovery care in Texas, and I did not put it in here, but also the state of Texas would not let Aetna put on the home care rider for 52 weeks. So Aetna launched a Texas-only product that it looks and feels just like the recovery care home care rider. It's 1 year and under of any type of home health care, medical or non-medical home health care. Believe it or not, that plan pays $3,000 a week in benefits. So if you're in Texas, you have a very special home health care plan there from Aetna.
All right. Looking to see if we have any other questions. I think that might wrap it up here for today. Just want to thank everybody for joining us today. Been a great session. A lot of people on this call. Just so you know, we are recording today's session, so we will have copies of that available for you. And if you have any questions, of course, certainly just reach out. Jamie, I think you probably got the closing slide there. There we go. Now, basically, if you have any other questions, need more of a one-on-one, or even if you need illustrations on this to see out how it works, obviously you can either reach out to me at ltci@jetter.com or to call me at the toll-free number right there. My extension is 1032. Again, Jamie, awesome. A lot of information as far as that goes, but definitely interesting to say the least. And, as evident by the number of people wanted to listen into today. So, thank you very much for your time. Thank you, everybody here. Unless anybody else has anything else, Jamie, I know you got another one of these coming up here. So I think that's all we've got here. Just want to say thanks for piloting today's session.
Thank you, everyone. Thank you, Tony. Everyone have a great day.
All right. Take care now.